Hello there. Welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. Our cases today come from that archive of cases, as well as one from our own institution. The patient is a 55-year-old woman who has been found to have a BRCA2 mutation. And so she comes for evaluation and prophylactic removal of her tubes and ovaries. So I thought it'd be useful just to review what the BRCA gene is and how it is involved with cancer. So BRCA1 and BRCA2 are two independent tumor suppressor genes located on chromosome 17 or 13, respectively. And these act to suppress growth, act as anti-oncogenes, and they also facilitate DNA repair, which, of course, as we know from the MSI data, is important in replicating cells. There are several hundred possible mutations in these genes that may result in various alterations and dysfunction. And so the landscape for these type of mutations is quite broad, and that presents lots of opportunities for oncogenesis. In terms of gynecologic cancers, the outcome is actually fairly simple. It's primarily serous ovarian carcinoma or serous tubal intraepithelial carcinoma, which may be the precursor for many serous ovarian tumors, and their corresponding tumors arising primarily from the peritoneum. Additionally, serous endometrial adenocarcinoma is more typically associated with BRCA1 mutation, not so much with BRCA2. The relative risk of ovarian cancer in these two scenarios is significantly higher with BRCA1, but both of them tend to increase the risk of oncogenesis after the age of 40. So our patient is several years beyond that. And as our gynecologic oncologist said, I usually like to do these at a younger age. So here's a representative section from the tube that is evaluated in her case, and we evaluated the entire sample that was submitted from both sides, both ovaries and the fallopian tubes. We use a particular protocol, which I'll talk about in just a moment, to perform that. But as you can see from low magnification, not only these green marks, but an area of hyperchromasia is standing out just as slightly different from the other areas of the fimbria or the intratubal epithelium. And so coming into higher magnification, although this is minimally architecturally distorted in terms of growth, there's a little trace of solid growth right here, but everything else seems to be on the surface of the fimbria. The stroma appears to be fairly normal. And so let's take a higher magnification look at these cells that are here and see the nature of what we're dealing with. Well, right off, we can see they're hyperchromatic. The nuclei are dark. They're somewhat variable in shape and size. There are mitotic figures. They may tend to stratify a little bit, round up a little bit. And we don't see the usual ciliated functionality of tubal epithelium here. We don't see much in the way of stromal reaction. And just this little bit of indenting growth with here an underlying benign portion of tubal epithelium is all that we have to highlight this as a potentially early invasive cancer. Now, because the growth and the orientation of the tubal fimbria can be quite variable, you can sometimes have more than one area that are involved by this process. So with that appearance and multiple sort of spread areas around this lesion here, we go to here, And then I think as we jump up over here, we will see other areas as well. Now, as we know, this pathway of serous carcinoma is closely related to mutation in the TP53, which is a gene which is also a tumor suppressor gene. And not unexpectedly, that immunohistochemical marker can be very useful. And it was strikingly positive for mutated status in this sample. Well, I mentioned that we use a particular protocol to examine these specimens when they're removed prophylactically, because the last thing you want to do if someone's had prophylactic surgery is to miss their early cancer and deprive them of the chance for potentially curative treatment at a very low stage. And so typically, if this is the fimbriated end of the fallopian tube, we want to expose the maximal amount of the fimbria to histologic examination. And so this perpendicular expression through the long axis of the fimbria is appropriate, whereas cross sections may be suitable for the more tubular portion of the fallopian tube. Additionally, when the ovary is resected in these patients, as is usually the case, these should also be sectioned to maximize the surface area of the ovary that is examined. So perpendicular to the long axis of the ovary should give you the maximal exposure of that tissue. So just to give you a couple of other examples, here's another example of a fallopian tube. And again, at low magnification, you can see there's an area that looks a little different. This is not just microscopic disease. This is beginning to show a little more architectural complexity. We don't have mass lesion formation here, but we can see that the architecture of the surface epithelium is altered. Maybe we have one or two little glands sort of extending downward from the tube. Here's another little isolated area over here that's positive. And microscopically, again, we see this high nuclear grade, disoriented, mitotically active, high NC ratio type of neoplasm that we would characterize as being serous carcinoma in situ. So this is also goes by the name of a STIC lesion, serous tubal intraepithelial carcinoma. If you like acronyms, that is the one that is in widest use in these cases. Another case here, just another example to give you practice. I'll leave this slide for you to come back and examine and see if you can determine where the area of serous tubal intraepithelial carcinoma is, because this highlights the fact that it doesn't always jump out at you at low magnification. And I'll give you a clue that this is not the area here where we have a little tissue fold. So there's a little challenge for you to come back and examine the digital slides, the link for which is in the comments description of the video beneath the facing page. Well, so thank you very much for joining us. Our case today, serous carcinoma high grade arising from serous tubal intraepithelial carcinoma of the fallopian tube. This patient actually did also have a small implant on the ovary. And so that's why we use this term serous carcinoma rather than just STIC in this situation. Well, thanks so much for joining me. It's been a pleasure to have you, and I hope that this has been instructive for you and useful as you evaluate specimens, treat patients, and manage these challenging genetic and molecular genetic and histologic abnormalities that we account. As always, we hope that you'll subscribe to the channel and please like the video so that ratings go up and we can attract more viewers, because we're trying to provide a service. And so sharing it, liking it, those kinds of things all add to the value that we're trying to generate here. So until next time, thanks so much for joining me.